Good morning, everyone, and thank you very much indeed for inviting me. I felt like a real interloper in coming in among such incredible experts. But I have to say it's been a really, really helpful induction for me about the whole issue of hepatitis C. I'm a practicing clinician, 2.5 days a week. I work in it's an assertive outreach stroke community forensic team. And about 80% of the people I work with have substance misuse as one of the kind of major difficulties they have, as well as, in addition, having some psychosis. Many people have suffered terrible physical, sexual, or emotional abuse, so they have interpersonal difficulties that have really made life very hard for them. And many of them have had a lot of contact with the criminal justice system. So although I'm not a substance misuse expert per se, I am an extremely interested general adult psychiatrist. And I'm also kind of slightly embarrassed to say that until I had the fabulous briefing provided to me by Claire, wonderful briefing, and many thanks as well to Owen, my whole knowledge of this field really, really needed increasing. So what I just wanted to say to you is, A, I've come from NHS London, not because I'm an expert, but because I wanted to make absolutely sure that you were all aware of just the incredible support we would like to give to you in addressing this problem. I'm also, as David says, I'm here because I'm a bit of an apparatchik. Over the years, I've always felt that it is incredibly important to have experts from the field involved in national and regional policy making. And there really are not enough of us. There are very few people who will put their head above their own organisation and come and help make national and regional policy. So there's also an invite to you to try and help me help you by getting engaged in some of the new policy world that's coming around. Now, David has already, Claire's fantastic briefing, told you the scale of the problem. Very, very helpful. So I think one of my first questions is, so what does that mean? And one of the things I wanted to firmly put on the table is that the whole issue of inequalities in London and inequalities for people with mental health conditions is really very, very significant. I've put this up as a bit of a kind of a, we've all arrived, let's just kind of wake up first thing in the morning. You can see the scale of the kind of extent of young people in London, particularly, who are committing suicide, compared to many other conditions. We've had fantastic investment in London in the stroke, completely re-engineering stroke services, re-engineering road traffic accidents. We've got a fantastic trauma service for London, from which about 500 people will benefit. But for the approximately 9,000 people in London who we think commit suicide annually, we yet have no major programme. And one of the things I'm lobbying very hard about is, can we start seeing suicide and severe depression, which is treatable, as the mental health MRSA? There are areas across the world where they have focused very hard on addressing depression and suicide in a way that we've not been able to. And many of the people who go on to commit suicide have had a substance misuse problem. So this is a really important issue for London. I think my messages, but these are the messages to me, and I would really look forward to the outcome of this conference. But to me, the key issues are, one is, how do we spread the word that physical health and premature mortality among the client group we serve is a really important issue? And I'm going to give you some stats in a minute. I want to just, in a sense, just as I've become much more knowledgeable about Hep C and the problems by reading all your work, I also want you to know about what's going on in the rest of the mental health world around the massive comorbidity of people having diabetes, coronary COPD, coronary heart disease, cancer. I want you to think a bit about, but you may be much more expert than we are in the mental health world, about the need for outreach. I think the days when you can sit in a clinic somewhere waiting for somebody to be motivated to come along have got to be long gone. It's just not sustainable in today's world when we look at the outcomes that are happening for the people with the most difficulties. And my challenge really to you is to help us think about, how do we get people to keep their basic skills up to date? How does a jobbing general adult psychiatrist like me learn more about your world? How can I keep up to date with all the innovation that you're doing? What do we need to communicate better? And I suppose finally, a real plea. To me, the most important people we've got to help our patients are staff. But if staff aren't trained, and we've had a Care Quality Commission staff survey of mental health staff in London, and in fact nationally, and what that shows is that less than 25% of staff working in mental health services feel remotely qualified to even ask about or assess if somebody has a drug or alcohol misuse problem. Now that can't be right, given what we know the prevalence to be. So kind of my challenge to you is, can you develop some e-learning for us? Can you kind of educate us, those of us jobbing people that haven't got probably either the time or the knowledge to come to a really good conference like this? Now, inequalities, I just wanted to raise the issue. In London at the minute, we have a big programme on something called a sequin, which is a kind of commissioning for quality. Because what we've realised is that people with schizophrenia are dying 25 years younger than the whole rest of the population. And people with other psychoses are dying anything from 10 to 15 years earlier than the rest of the population. And the reason for that is because they have such high levels of physical health conditions that are not assessed and not treated. So don't feel alone in your concern about Hep C not being recognised, because we have as great a problem in terms of people not being recognised as having these conditions. If you take someone with schizophrenia, for example, genetically they are 5 times more likely to develop diabetes. If in addition they then have some of the medications that we give them for treatment, they are 12 times more likely to develop diabetes. Now that fact is often not known across primary care, who mainly deal with physical conditions, and even in mental health services. And I suppose one of my questions is, in the world of substance misuse, where you deal with people with comorbidities, mental health, substance misuse, physical health, how known are these facts and figures? And I just thought I'd put one stark figure at the top, that women who have schizophrenia, and schizophrenia is a bit of a loose term in many ways, it could be people with major drug-induced psychosis, who knows, are 40 times more likely to get breast cancer than other women, and to not have it recognised. People are much more likely to get bowel cancer. So again, when you're seeing, if you are seeing people with psychosis, with Hep C, think about these physical comorbidities as well. Make sure they can access primary care or somebody who is aware of what's going on for them. Now, the second thing I said I would talk to you about is the need for outreach. Let me just explain, I suppose, what happens. In the main, I think many of us have had the assumption that if somebody has complex problems, substance misuse, mental health, and they need a good annual physical check, that will happen with a GP. But if you think about it, each GP, and I'm sure there's some in the audience, have 18 to 1900 people on their list. So one of the requirements of government policy is that GPs set up a register of people with diabetes, a register of people with severe mental health problems. And there is an expectation, or I suppose we've all had the assumption, that if somebody has got that condition, they'll be called in for an annual check into their GP. And what we are finding now from this commissioning sequin initiative in London is that in many parts of London, less than 20% of people who have these conditions are accessing an annual physical check. Now, when you know that, it begins to explain why the morbidity, the 25 years earlier deaths, are so common in our population. And this is not me, nagging at GPs. It's a very, very difficult job being a GP. But these patients, these hard to engage patients, we need outreach. We've got to get out there and see people. And in many ways, we've got to make it easier for people. Because I know my patients they find it hard to remember to wake up and have fasting blood tests. If you've had medication the night before and you're not feeling great, remembering to fast the next morning, to not take the medication, to take 2 buses to a path lab to get the blood test done. Very, very difficult. I think the whole challenge is how do we get out there and actually engage and help work with the people that need us to kind of motivate them to get around.